Hello, everybody. I'm David Burney from the Ottawa Heart Institute. I recently shared results from the Ocean trial showing that many patients with atrial fibrillation who've had a successful ablation may no longer need long-term blood thinners. Now, our original video has now been viewed 160,000 times all over the world, and we've had lots and lots of questions coming back to us. So I'm here today just to run through some of the most frequently asked questions. So here we go. The top question that we've been asked so far is, should I stop my blood thinner now? And the answer to that is no. You should contact your doctor first, because there are some nuances to the trial. Most patients will be able to stop their blood thinners, but not everybody. So you should contact your local doctors and just do it under their guidance. Second question is, does this apply to everyone with atrial fibrillation? And the answer to that is absolutely not. This is just for patients who've had a successful atrial fibrillation ablation. And not everybody's a candidate for ablation, and not everybody has a successful ablation. And success is really defined by your doctor. Don't just think it's a success and stop your blood thinners. Clarify with your doctor before you stop your blood thinners. Next question is, will you go on to study whether ongoing use of blood thinners is necessary for patients who've not had an ablation, but whose atrial fibrillation is controlled by medication? That's another excellent question. And the answer is that question has already been studied some years ago by a very similar trial. And what was interesting is that they found the opposite result to what we found. Specifically, they found that if your atrial fibrillation is controlled by medication, you still have to continue blood thinners. Now, I don't have time to go into the nuances of why there's a difference in result, but the result is very clear. For patients on meds, you should not stop your blood thinners. And patients after successful atrial fibrillation, it's 100% the different direction. Next question, why are some patients not candidates for ablation? Well, some subtypes of atrial fibrillation are, just don't respond to ablation, unfortunately. Primarily patients who've been on atrial fibrillation persistently for years and years. The longer you're in atrial fibrillation, the less likely ablation is to be successful. So long-standing atrial fibrillation, generally, those patients are not candidates for ablation. These are excellent questions. What about recurrent atrial fibrillation? There are usually multiple foci that develop over time, i.e. significant risk of recurrence. Very important point. The chance of a recurrence after a successful ablation is somewhere between 1% to 3% per year. And, as soon as you do have a recurrence, you need to go back onto your blood thinners, and you need to be in touch with your doctors about next steps. Has this information been made available to all of the cardiologists at the Heart Institute? Yes, this information has been given to all of the doctors at the Heart Institute. It sometimes takes a while for doctors to fully understand new science. So just keep pestering your doctor, and you will get a good answer from them soon. Do you think this will push more recommendations for ablation as first-line treatment for atrial fibrillation? Access is challenging, as it is for this procedure, but if we can reduce DOAC use, I think that's a great thing. I think the answer to that is yes. I think it's in some subtypes of atrial fibrillation, this should be first-line treatment now. For patients with paroxysmal atrial fibrillation, it can really, really change people's quality of life. And now we have this additional benefit that many patients can stop their anticoagulation. So I'm very hopeful. I think what will happen is that more patients will be referred, so more patients will go onto the waiting list, so the waiting list will grow, but then Ministry of Health will respond to that growing waiting list and give us more resources to do more ablation. So I'm very hopeful that the capacity to do ablation will increase. Next question, very important question. Did you include an echo representation of women in your study? The answer to that is we did, but there's a nuance there, and that is in the world, for some reason that we don't fully understand, if you look at ablation populations, only 20% of general ablation populations are women. We don't know why that is, whether it's because atrial fibrillation just behaves differently in women. There's a lot of study going on into that. The last question, and this is another excellent one, ablation has a significant risk, so why do it? again, very important question, and I often give patients in my own clinic the analogy of my hip. So I've had arthritis of my hip for 20 years, and for 18 years I struggled on with Advil for flare-ups, and then 2 years ago it got so bad that I had to bite the bullet and get my hip resurfaced. So it's a little bit the same for atrial fibrillation, and it's a very individual discussion as to at what point it becomes such a pain to your life that you want to undergo the ablation and take that small gamble of the risk of the ablation. And I say a small gamble, it really is a pretty small gamble these days. The procedure is much, much safer than it used to be. But there is, with every procedure, a small risk. So, and it's very individualized at what point it tips for you from being such a nuisance that you want to go through that ablation. Anyway, that's all we have time for just now. Thanks for all your questions. If you want to learn more about the OCEAN trial, or about atrial fibrillation, or about ablation, please visit our website. We're very, very excited about these results. I was over in Germany at a conference last week, and this is changing practice in Germany, it's changing practice in Canada, it's changing practice, all over the world. So very, very proud of these results.